Good morning, everyone. My name is Selvi Thirumurthi. I'm a gastroenterologist at the University of Texas MD Anderson Cancer Center, and I will be hosting the Zoom class this morning on gastric anatomy. I'd like to thank my dear friend and colleague, Dr. Raju, for inviting me to participate in this wonderful educational program. I'd also like to thank Dr. John Stroline, the chair of our Department of Gastroenterology. He is our champion and a great supporter of all of our educational endeavors. And I'd lastly like to acknowledge Angela Deal, medical illustrator extraordinaire, who really brings to life and puts into context a lot of the um, ideas and concepts that we'll be talking about today. These Zoom classes are uploaded onto Dr. Raju's YouTube channel. So I would encourage you to let your colleagues know about um, these programs that are available and free to access for everyone. So let's go over an outline of what I'll be covering today. Because we have a mixed audience of GI trainees, fellows, um, endoscopy nurses, and endoscopy technicians, all with different levels of experience. I wanted to just have a broad outline of topics for discussion. So the first thing that I'll discuss are why are patients coming for an upper endoscopy procedure? Then we'll go over the anatomy so we can review what are the different parts of the stomach that we're either looking at or examining during an EGD procedure, and how these different segments of the stomach actually contribute to digestion and other purposes. And because we're in a cancer center, there are many interventions that we can perform that are related to cancer um, treatment during an upper endoscopy procedure. And a lot of the cancer treatment can also involve surgical procedures. And I wanted us all to be able to recognize some of the common post-surgical anatomy that we'll see during an EGD. So why do patients come for EGD? And first of all, what is an EGD? So an EGD stands for esophago, gastro, duodenoscopy. So these are the three organs that are examined during the course of an upper endoscopy or EGD procedure. So common indications for this procedure include upper abdominal pain or dyspepsia, which is derived from the Greek to mean disordered digestion or maldigestion. Another indication for an EGD procedure is anemia. So this is a low blood count, a low hemoglobin and hematocrit, or low iron stores. Consistent with iron deficiency anemia. So patients can be anemic because of GI bleeding. So GI bleeding can be overt, meaning patients are having dark tarry stools, or hematemesis, emesis of heme. So this can manifest as vomiting bright red blood, which is an emergent procedure for evaluation and hemostasis, or it can be vomiting of partially digested blood, where it looks like coffee grounds that you see in your filter in your coffee maker in the morning. So GI bleeding can be overt, meaning the patient is manifesting the bleeding, or it can be occult, meaning you presume the patient has a GI bleed and because they are presenting with anemia. The GI tract is, after all, one of the most common sources of blood loss and subsequent anemia. GI bleeding can, in addition to being classified as overt or occult, it can also be classified as obscure, meaning you have done a thorough evaluation with an EGD procedure, a colonoscopy, maybe a capsule endoscopy. However, you're not able to identify the source of the bleeding, and this is considered obscure GI bleeding. Other causes include nausea and vomiting. So this can be non-cancer related, as I mentioned. It may be related to the cancer itself, or it may be related to treatment for the cancer. So commonly chemotherapy, less commonly immune-mediated therapy can cause nausea and vomiting symptoms. Early satiety is another indication for an EGD. So that simply means that patients start feeling full before they've finished eating what they would normally be able to eat without any difficulty. Another indication is diarrhea, and you might think that diarrhea sounds like it's a lower GI problem. Why would you do an upper GI procedure? There are conditions in the upper GI tract that can cause diarrhea. So, one example would be gluten sensitive enteropathy or celiac sprue, celiac disease. And to evaluate this, you would do an EGD procedure and do biopsies of the duodenum. Another cause for both anemia and possibly diarrhea is Helicobacter pylori infection. So, this is a common bacterial infection that involves the stomach. And so, you would have to do biopsies of the gastric body and antrum for that. So, what are some cancer related indications for an EGD procedure? Because we work at MD Anderson. So, there's a few of these that we'll talk about. So, screening. So, looking for gastric cancer or pre malignant lesions in the stomach in patients who are at risk for gastric cancer. Who is at risk for gastric cancer? Well, patients who have a family history of gastric cancer should be screened themselves. Patients who are either Asian ethnicity or Hispanic ethnicity are at increased risk for gastric cancer, and they should be screened. And the area that I primarily work in, which is hereditary cancer syndrome, so there are certain syndromes that have a very high risk of developing gastric cancer. So one example of this is hereditary diffuse gastric cancer, which involves the CDH1 mutation. And other syndromes such as FAP or familial adenomatous polyposis are also at risk for developing precancerous lesions and gastric cancer. So these are the patients that would be in the screening category. Diagnostic for cancer. So if a patient had symptoms and had cross-sectional imaging, such as a CT scan or a PET scan, and this shows a lesion within the stomach, then those patients would need a diagnostic exam with an EGD to evaluate the tumor and get biopsies. Once a patient has cancer, staging is another indication for an EGD procedure. So specifically, this would require use of an echo endoscope or an EGD scope that has ultrasound capability built into it, and we're able to evaluate the depth of the tumor involvement within the wall of the stomach and also to evaluate regional lymph nodes. Restaging is another indication that patients are referred for. And this is where patients have with gastric cancer have had some treatment, such as chemotherapy or radiation. And prior to surgery, these patients are referred for a restaging procedure where the current size of the tumor can be evaluated and compared to the previous pretreatment tumor, and biopsies can be obtained. Small gastric cancers that are limited to the superficial layers of the stomach wall can be primarily treated with an EGD procedure, along with a technique called ESD or endoscopic submucosal dissection. So, one of our colleagues, Dr. Philip G., is an expert in this particular technique, and he's able to remove even large tumors from the stomach as long as they are limited within in terms of the depth of the tumor involvement. Um, Upper endoscopy procedures can be used as an adjunct to cancer therapy. So, patients specifically who are not able to eat due to radiation, so head and neck cancer or lung cancer, who've had radiation and are not able to swallow, can benefit from a PEG or percutaneous endoscopic gastrostomy tube placement, and that's placed during the course of an EGD procedure. After patients have survived their cancer, they next go into surveillance. So, after surgery, for example, patients are referred for routine surveillance exams to evaluate the anastomosis or surgery site. And surveillance is also indicated for patients with pre-malignant lesions, as I mentioned earlier. So, one of these would be intestinal metaplasia. Patients with intestinal metaplasia, changes of their gastric mucosa, are at risk for developing gastric cancer and therefore require routine surveillance exams with biopsy. And lastly, patients who have gastric outlet obstruction, for example, can benefit from a palliative procedure such as an upper endoscopy with an enteral stent placement that will show a little bit later in my talk. So, briefly, the stomach can be considered to be a conduit or a connection between the esophagus and the duodenum, but it actually does quite a bit more. Obviously, it's involved in digestion, as you would imagine, but we'll talk about how the stomach is important in GI motility and in microbial defense. So this is a nice illustration of a cross section of the gastric body. So the innermost layer, it consists of the mucosa. This is the layer that's closest to the lumen. The mucosa consists of the epithelial layer, the lamina propria, and the muscularis mucosa. The next layer out is the submucosa. The next layer out from that is the muscularis propria layer, and out from there is the serosa. And remember, in with the esophagus, the outermost layer was called the adventitia. In the rest of the GI tract, it is called serosa. So the muscularis propria layer is very specialized in the stomach, and for multiple different reasons. So the first reason is the fact that there are three layers of muscle in the muscularis propria, where other organs only have one. The second reason is that these three layers are not one on top of each other, but all at different angles to help one of the main functions of the stomach, which is breaking food particles down into very small fragments. So the first layer of muscle is the longitudinal layer. So this runs along the long axis of the stomach. And if that contracts, basically it foreshortens or contracts the stomach up. The second layer of muscle is a circular layer. It runs 360 degrees around the axis of the stomach. And when that contracts, it's basically going to squeeze the stomach in. The third layer is called an oblique layer. It runs at a different angle from the longitudinal and circular muscle layer. And so when it contracts, it actually helps churn the food down and mix it. So another reason why the muscularis propria layer is so specialized in the stomach is it contains pacemaker cells. So we know the heart has pacemaker cells and the stomach does as well. And these pacemaker cells are very important to stimulate GI motility. We'll look at the different segments of the stomach. So, the stomach, the first thing to note is that it has two sphincters, the lower esophageal sphincter and the pyloric sphincter. These sphincters are thick circles of muscle that help control what enters and exits the stomach. So, the lower esophageal sphincter controls what enters the stomach, and the pyloric sphincter controls what leaves the stomach and when it leaves the stomach, and what size the particles are that leave the stomach and enter the duodenum. So the four main segments of the stomach are, first is the cardia. So this is the part that's the first section that you come to when you leave the esophagus. The second part is the fundus. This is a bowl-shaped part of the stomach. The third part is the body of the stomach. This is a large section of the stomach and is characterized by rugae, or thickened longitudinal folds that we all see when we watch an upper endoscopy procedure. And the last portion of the stomach is the antrum. So this is the part that actually connects the body to the duodenum. And within the antrum is an opening called the pylorus or pyloric channel, which is controlled by the pyloric sphincter. So let's talk about the functions of the stomach. So, as I mentioned, digestion is one of the main functions of the stomach. So, there are two types of digestion that the stomach does. One is mechanical digestion. So, swallowed food is mixed and churned by the muscle layers contracting in their different directions, as I've outlined. The second type of digestion is chemical digestion. This is basically breakdown of food by gastric acid. So gastric acid has a pH of 2 to 3, and so it's able to denature and break down food. And gastric juices also contain some enzymes that help the chemical breakdown of food. Interestingly, there's very little nutrient absorption that occurs within the stomach itself. And The second function of the stomach is, of course, the motility that we've talked about with the pacemaker cells. And the third function is microbial defense. So, of course, if you have gastric acid, it helps to destroy bacteria and other pathogens that can be swallowed. And that's part of our immune system, if you will. So this illustration shows the rich vascular supply of the stomach. Most of the stomach's arterial blood supply comes from the celiac axis or celiac trunk. And this is the first main branch off of the abdominal aorta. And it's this blood supply that helps the stomach carry out all of its important functions. So my apologies here to Angela. I've corrupted one of her beautiful illustrations to show me doing an endoscopy procedure. So I took some poetic license with your illustration, Angela. My apologies. So we'll start looking at the stomach. The first part of the stomach that we come to is going to be the gastric cardia, and this is just below the lower esophageal sphincter. It's important to examine this area first because you can get cancer of the gastric cardia. It's often indistinguishable from GE junction cancer or distal esophageal cancer. The way to examine the cardia is based on a retroflexed view where you turn the scope to look on itself. The gastric cardia is the part of the stomach that is hugging the scope on the endoscopic images. It's important when you're doing an exam of the gastric cardia and the fundus for that matter in retroflexed view that we rotate the scope 360 degrees so we can see both the greater curvature aspect of the cardia along with the lesser curvature aspect of the cardia. This is an example of another reason why we need to take a close look at the gastric cardia. If the cardia is not closely hugging the scope in all 360 degrees, then there is a gap between the stomach and the scope. This is often suggestive of a hiatal hernia. So a hiatal hernia is simply where part of the stomach protrudes through the diaphragmatic hiatus into the chest or thoracic cavity. And it's seen both on retroflex view to look like this and in antegrade view to look like how I will show in a video that I have a little bit later on. So hiatal hernias can be measured a couple of different ways. One way is antegrade to measure the length of the hernia, the distance between the top of the gastric folds and the diaphragmatic pinch. And in retroflex view, there is the Hill flap valve classification system where you can classify a hiatal hernia. The next part of the stomach is the gastric fundus. The wall is thinner here in the gastric fundus. So when we take biopsies, sometimes we are quite aware of that with more bleeding or oozing that can happen post biopsy in the fundus. The purpose of the fundus is something called receptive relaxation. It's got a thinner wall, it can relax, and it actually holds the food that the gastric body is not yet ready to process. So it holds the food, and once the gastric body empties, then it releases additional food for the gastric body to process. And again, the fundus is examined on retroflexed view, and a 360-degree view should be taken. The next part of the stomach is the gastric body. The purpose of the gastric body is to fill and then mix or churn the food using the 3 layers of muscle that we discussed earlier. It's characterized by the rugal folds, these longitudinal folds of the gastric mucosa. I put some markers here on the endoscopic images so that we can distinguish the lesser curvature from the greater curvature. The greater curvature has most of the rugal folds, the anterior wall from the posterior wall. One easy way to identify the anterior wall for first year fellows will be where you see a gastrostomy tube or feeding tube come in. That is placed through the anterior wall of the abdomen, and it comes through into the anterior wall of the gastric body. This next portion of the stomach, or the fourth portion, is called the antrum. It has no rugal folds. Known as the pylorus or pyloric channel. I do routinely take a look and stop in the pyloric channel and look for ulcers or any other pathology. Another kind of anatomic feature of the stomach is called the angularis, or incisura. You can often see ulcers, both benign and malignant, at the incisura, so it is important to examine it. It's a part of the lesser curvature, and it's seen when you start retroflexing to look at the cardia and fundus. This is, if you start retroflexing in the antrum, this should be the first part of your retroflex views. So here I have a short video that I've edited, of a recent upper endoscopy procedure that I did for a patient. If I showed you the entire upper endoscopy, it would take 15 minutes of the time that I have for my class today. So I've um, edited it so you can just see the salient features. So here we see erosive esophagitis, and I examine the distal esophagus and take many pictures. And as we're entering into the gastric body, you can see a hiatal hernia that we just went by. The first thing I do when I get to the stomach is to suction out any fluid that's already there. And when I use simethicone solution from my endoscopy technician, or I use my foot pedal to wash away any bubbles, I'll immediately pull back to the proximal gastric body and suction out any fluid in order to decrease aspiration risk, as all of our patients are done with deep sedation with propofol. Now we're approaching the gastric antrum, and we can see the opening in the gastric antrum, which is the pyloric channel or pylorus. Beyond this, of course, is the duodenum. As I'm starting to retroflex, that's the angularis or incisura. The full retroflexion in pulling the scope back to examine the cardia and fundus. It's a little bit challenging in this patient because he has that large hiatal hernia, which you can see here, where I'm washing, taking some of the bubbles away, and then suctioning out the fluid that I put in. In patients with hiatal hernias, often they're passing a large amount of air while they're under deep sedation, and sometimes giving very gentle cricoid pressure can help them retain the air and optimize your exam. And there's the hiatal hernia in retroflex view. There's the cardia and the fundus. And I'm doing a 360 view to examine both the lesser curvature and the greater curvature aspect of the cardia, and a full examination of the fundus. And every time I put water in to clean away bubbles or any debris, I'll suction that fluid out immediately, again, to decrease the risk of aspiration. So I'll straighten out the scope here and do another look at the gastric antrum and of the gastric body. When I do my exam, I first look under white light, and then I'll switch on the narrow band imaging and examine the gastric mucosa using NBI as well. It's important as trainees to establish a consistent pattern of examination, so you don't forget to examine certain parts of the stomach. And by consistency, you make it a habit and do a very thorough exam each and every time. And see here, it's difficult to insufflate. So there's the hiatal hernia, and then there is the Z line and the erosive esophagitis. And here at this point, I'll take a look with narrowband imaging and then do biopsies. So briefly, we'll talk about gastric interventions that we can perform during upper endoscopy procedure. So this falls under the palliative category. So this is a patient who has maybe duodenal adenocarcinoma or pancreatic adenocarcinoma that's invaded into the duodenum and results in a gastric outlet obstruction. So the antrum cannot empty into the duodenum because there is tumor blocking egress of food particles. So what we do, what our therapeutic colleagues at MD Anderson do is place enteral stents. So these are metal stents that they place under fluoroscopy or under X-ray. They advance a wire under X-ray through the tumor, and then over the wire advance a catheter where a stent has been preloaded, and then they deploy the stent, again looking under X-ray to make sure that there's proper placement. And this is palliative. It doesn't actually help cure the cancer or treat the patient, but it does improve their quality of life. And there's a lot to be said for that. Patients are able to manage their own secretions. Gastric acid is able to empty from their stomach. They're able to drink liquids, and then they generally are put on a modified diet so that the stent does not become occluded with food debris. This is another intervention that we commonly perform. This is a percutaneous endoscopic gastrostomy tube internal bumper. So the bumper is this is placed during the course of an upper endoscopy procedure. The internal bumper has a hole in the middle. This hole is attached to the tube that extends outside of the abdominal wall, and so food, and tube feeds, and medications can be infused through the tube and into the gastric body. These tubes, once they're placed, generally have to remain in place for at least 4 to 6 weeks before they can be removed. Removal generally is at the bedside with simple traction on the tube. This internal bumper is rubber and can collapse and come through the opening in the abdominal wall. Um, so if the patient's finished with their cancer treatment and they don't need their tube anymore, it can be removed. If they need to have their tube for a longer period of time, generally we replace them with these replacement tubes, and that's just done at the bedside at the time of replacement. No sedation, no endoscopy procedure, and this is a internal bumper of a replacement tube. So whereas the original tube was collapsible rubber material, the replacement tube is a saline filled balloon. So over time, gastric acid can erode the balloon and compromise its integrity. And therefore, we usually have patients come every 6 months or so to change their replacement tube out, again, just at the bedside by deflating the balloon, pulling the replacement tube out, putting a new tube in, and inflating the balloon, and then checking for gastric contents to confirm proper position. This we do not have the monopoly on gastrostomy tubes, so our colleagues in interventional radiology can also place these tubes. So if you see a patient who's had a tube that's been placed by interventional radiology, this is what it looks like. It's a pigtail catheter, and there's certainly holes in the catheter where the tube feeds can be instilled. And these IR tubes are of a smaller diameter than our tubes. So our gastrostomy tubes are generally 20 French, and the IR tubes are generally around 18 French. So the last part of my presentation will be to look at some post-surgical anatomy at our cancer center, and then certainly in non-cancer centers, you'll see patients who've had surgeries that involve the stomach, and so it's important to be able to recognize or be familiar with some of this anatomy. So the first thing that we'll talk about is the sleeve procedure. This is done for bariatric or weight loss purposes, where the stomach is sectioned longitudinally along its long axis, and the greater curvature part of the stomach is removed. This is a restrictive type of surgery where patients are only able to eat very small amounts of food. They feel full and they stop eating, and that's how patients lose weight. So I pulled from my file some endoscopy images of patients who've had a sleeve gastrectomy. I think you can appreciate that many of the gastric rugal folds are missing because much of the gastric body is missing. You have suture lines that are longitudinal where the stomach has been re-anastomosed together. So this is a Billroth 1 type of procedure. So Christian Billroth was an Austrian surgeon who did the first gastric reconstruction, and that was actually done in 1881. So you may see this type of anastomosis. It's a gastroduodenal anastomosis and can be accompanied by a partial gastric resection. So you can see that the antrum portion of the stomach is missing and has been anastomosed or attached to the duodenum. Another type of anastomosis is the Billroth 2. So this is a partial gastrectomy with a gastrojejunal anastomosis. And so when you leave the stomach, you'll see two openings. So there will be an efferent limb, which leads away to the jejunum and the ileum, and an afferent limb where the duodenum and digestive juices, bile, etc., pancreatic juices come from the ampulla of Vater from the second duodenum, which is intact, and mix in the jejunum. And the last type of gastric reconstruction is a Roux-en-Y gastrojejunostomy. This can be done for weight loss as well, where the stomach can be sectioned to a very small gastric pouch remnant, and then anastomosed to a loop of jejunum that is brought up. So when you leave the stomach, or what's the left of the stomach, you'll see small bowel. You'll see two entrances. So one will be just the blind jejunum that you can see to the right of the screen with the suture material. And then the other end will be the efferent limb, where as you go down, you may encounter the uh, duodenojejunal anastomosis, or the Roux limb. And depending on how the surgeon, how long they leave the Roux limb, you may or may not actually find this third anastomosis. So here is a gastrojejunostomy procedure. This is a palliative procedure for patients who have either duodenal tumors or antral tumors. And this basically is a way to vent the stomach and still be able to eat. And so they bring a loop of jejunum up to the greater curvature of the stomach. And when you insufflate, you can see that there's two limbs that can be evaluated with the scope. And this basically, again, helps the patient empty their stomach of gastric juices, liquids, and some modified diet. So, in summary, we talked about why patients present for an upper endoscopy procedure. We talked about the four segments of the stomach: the cardia, fundus, body, and antrum pylorus. We talked about the different functions of the stomach, which include mechanical digestion, chemical digestion, GI motility, and antimicrobial defense. We talked about some of the cancer related interventions that we can do both as an adjunct to cancer therapy, such as gastrostomy tube placement, or palliation from cancer, which includes an enteral stent placement. And then I reviewed some of the more common post surgical anatomy that you can encounter when you're seeing patients both in the cancer and non cancer setting. I thank you very much for your kind attention. Um, and I thank Raju for the opportunity to participate in this Zoom educational program. Thank you.